is my patient assessment video. So I was dispatched to a fall. So BSI, scene is safe. I have one patient. I am going to form a general impression of the patient. So coming up, I see an elderly gentleman who appears to have had a fall. Patient seems unresponsive at first glance. So I am just going to assess his level of consciousness. So, sir, can you hear me? Patient does not respond to any verbal stimuli, painful stimuli. Got a little twitch, but no response to painful stimuli. So the patient is unresponsive. It's not conscious. So I'm going to have my partner hold manual stabilization of the spine while I assess the airway. I'm going to use jaw thrust maneuver because of the nature of the fall. So there was the trauma, so I'm going to push the jaw forward, open the mouth, and check the airway. So the patient appears to have a patent airway, but I can tell from the lack of chest rise that the patient is not breathing on their own. So I'm going to insert an OPA or an NPA, and then I'm going to hook up the patient to high flow oxygen on a BVM. I probably want additional help because I would want other hands to come in and help apply cervical collar while I was doing the airway and assessing the patient further. So we would want a cervical collar on at this time so that my partner didn't have to hold spine stabilization anymore. So I would consider maybe getting some extra help, especially with potentially lifting the patient. So I have him on high flow oxygen, so like 15 liters with a BVM. So we're doing, about 10 breaths per minute with the BVM. I'm going to assess for a carotid pulse. There is a pulse present, but it's rapid, weak, and thready. So due to how the patient is presenting, I'm starting to think that maybe we have some form of shock going on here. I don't notice any gross bleeding off the bat. So I've done my airway breathing, my oxygen therapy. So now I'm just gonna see and figure out if I see any outward signs of trauma. So I'm just going to go down the patient's body, noting for any blood on my gloves. I don't seem to see anything at this juncture. So there is no gross bleeding noted, but that's just that. So assessing the skin seems pale, cool, and diaphoretic, so this is leading me more to think that the patient is going to be shocky. So I am going to probably have my partner start 1 or 2 18-gauge IVs. I'd like normal saline in there. If we have a warmed fluid, that would be best for the patient. And going to make my transport decision on this patient is obviously a high priority patient. So I'd like to grab a quick sample history from the family before we go. So I'd be checking for signs and symptoms, allergies, any allergies to any medications. Are they taking any medications? Could they have taken too much? Could they have forgotten their medications today? Any past pertinent information that I need to know about. Last oral intake, when's the last time he ate? And events leading up to what was going on. Did he stumble and fall? Did he lose consciousness? Was he acting odd before the fall? Those are all things that can help me put together the pieces of the puzzle. I think this patient has a GCS of 6. Their eyes are not responsive. There's no verbal responses. There's no flexion or extension. There was kind of a wince with the painful stimuli, so I would give them a 6. Once we got them on the truck, I would have the heat cranked to keep them warm. We'd have the warm IV fluids going, and then I would get the patient trauma naked just so I can assess the body further to look for any deformities in the body. So I'm going to just palpate the head, looking for any crepitus, anything moving where it shouldn't be moving. I'm going to assess the zygomas. I'm going to look at the ears, make sure I don't see any spinal fluid coming out. There's no obvious bruising or lacerations. I'm going to check the pupils, see if they're normal and reactive to light. I'm going to look for tracheal deviation. I don't see any. I'm looking for JVD. I don't see anything there. I'm going to assess the cervical spine, checking for any step off, anything that doesn't feel right. I'm going to check the collarbone and the shoulders here. I'm going to assess the rib cage and palpate the 4 quadrants of the abdomen. I'm going to assess the limbs, checking for distal pulses, checking for CSMs as I can. So it's hard with an unconscious patient, but I would be looking for circulation there if they can have sensory functions and motor functions. I'm going to check the pelvis, pushing in and down, looking for any movement, any crepitus there. Same thing on the legs. I'm going to check for distal pulses. I want pedal pulses. Not seeing any deformities, not seeing any bruising. Check the pedal pulse there. At this juncture, I'm going to roll the patient. So they do have the C-spine on. So I'm going to roll the patient towards me, checking for any step off, checking the posterior thorax, making sure there's no flail segments back here, checking the buttocks. I don't need to check the genitalia of the patient. I feel confident that that's not pertinent at the moment, but they are trauma naked. I'm checking the back of the legs. Don't see anything pertinent there. I'm going to keep the patient warm, probably cover them back up and get vital signs right away. So I would listen to the lungs, probably will listen to the lungs as I roll them on the back to make sure there's no absent breath sounds. Listen to the lungs. Oh, my bell's gone. Listen to the lungs here. I would take a blood pressure. I want to get them on a pulse oximeter. I'd probably do some capnography. I would like to check a blood sugar just to make sure. I'm trying to figure out what the fall originated from. Was it medical? Was it mechanical? Just figure out what's going on. So that is that. I would reassess this patient every 5 minutes in transport. I would probably call a trauma alert at the hospital due to the GCS and what had happened there. So as I take the blood pressure, okay, so the blood pressure is 80 over 55, so that goes in coordinates with my shock theory. So I want to keep the fluids going, hoping to fix the blood pressure, keep the patient warm, keep them on the high flow oxygen, and continue to reassess, look for any changes, and I would go lights and sirens, and hope this patient is okay. And I also, because it's an elderly patient, would have probably, and right off the bat, something I forgot to ask the family, if they're a full code, if they're a DNR, that would change what people are going to do at the hospital. So just